السلام عليكم. أنا أحمد توفيق، طالب سنة تانية زمالة تالتة إن شاء الله. هقدم لكم كيس برزنتيشن النهاردة بعنوان dual tachycardia. Our case today is a 55-year-old female. She's not hypertensive, not diabetic, with no past history of medical illness. She complained of palpitations of sudden onset and offset since 8 years ago. She was admitted to CCU and received IV medication, and since then discharged on bisoprolol 2.5 milligrams once daily, and her ECG during tachycardia was lost. The palpitations recurred once or twice per year and always terminate by bisoprolol, and she was advised to do Valsalva maneuvers, and hopefully palpitations were terminated every time like this. Recently, she had increased frequency of attacks thrice in the last 2 weeks before coming to us, to our clinic, so she sought medical advice. Her resting ECG was normal and her echo was normal. She was advised to do an EP study. This is the 12-lead resting ECG with no pre-excitation seen, normal ECG. At the beginning of the study, this is the 12-lead ECG showing normal PR interval. We inserted a 6 French decapolar catheter into the coronary sinus, a 6 French quadripolar catheter into the RV and His region. We started by V pacing, and it showed concentric conduction via AV node with Winkelbach cycle length of 200 milliseconds. This is the V extra, and it's showing a decremental conduction. This is the decrementation. Atrial pacing showed one-to-one conduction via AV node, and then atrial pacing resulted in initiation of tachycardia with simultaneous A and V activation, which is AVNRT. PPI was attempted several times, but every time the tachycardia was terminated. So instead, we used this maneuver, measuring the VA time during tachycardia and during V pacing after tachycardia have been terminated. And here it shows 25 milliseconds of VA time during tachycardia and 155 milliseconds during V pacing after tachycardia. More than 85 milliseconds denotes AVNRT. We did atrial extra stimulus. This is at 500 over 390 milliseconds. The AH interval was 126. At 500, 380, the AH interval jumped to 228 milliseconds. H jumped more than 50 when we are decreasing, doing a decrement of 10 milliseconds, and S2 denotes H jump. In this case, it was 102 milliseconds. So we decided to ablate the slow pathway of AV node. This is during atrial extra, and we had echo beat and tachycardia. Tachycardia cycle length was 400 milliseconds. We inserted the 7 French non-irrigated ablation catheter via long sheath to the area of the slow pathway. Here we are trying to map the area of the slow pathway. We achieved a small A and a larger V with a ratio of approximately 1:5, and we started ablation at 35 watts for 2 minutes. These are things we should watch for during ablation of the slow pathway. First is the fast junctional. We should watch for fast junctional and stop immediately and reposition the catheters. We have consistency more than 3 beats in the same screen at a speed of 200 milliseconds. Millimeter per second is tachycardia. So more than 3 beats in the screen, we stopped immediately. We should also be cautious while ablating for non-conducted beats And here, as we can see, there is an unconducted PAC. So we stopped the ablation immediately and readjusted the position of the catheter. Here we achieved slow junctional rhythm, which is a good sign of successful ablation to the slow pathway. This is the site of ablation of the slow pathway in RAO and LAO. V-pacing after the ablation of the slow pathway showed that the retrograde is doing fine. Again, now we are trying to induce tachycardia during atrial extra stimulus pacing at 500 over 200. It resulted in a new tachycardia with long RP. This looks like atrial tachycardia. So we wanted to do the overdrive pacing and see the VAV response, but the tachycardia also unfortunately stopped every time. So we went for mapping. We achieved on the ablation. We achieved 37 milliseconds earlier than the earliest A on CS5 and 6 on the ablation catheter, and we started ablating in the coronary sinus ostium. This is the fluoro of the second ablation inside the coronary sinus ostium. Then the study was repeated with no induction of AV RT or atrial tachy, and this is the atrial burst pacing showing Winkelbach cycle length of 300 milliseconds. And this is the atrial extra with blocked beats. The take-home messages is that a full study should be done before or after ablation for all cases, and anticipation of any or different forms of tachycardia should be always there. Thank you.